For the American Psychiatric Association. Before the break, Dr. Primm, we were talking about the ways in which the illness of depression affects the minority population. And especially there's a concern about minority individuals not seeking help because of stigma and other reasons. But can you talk a little bit more about the way in which depression might manifest itself in minority populations, especially African Americans, Latinos, etc.?
Sure, I'd be happy to. Of course, members of the groups that you just mentioned experience depression in similar ways to the general population, but also may present in some different ways that people may not be familiar with. For instance, among Latinos, concerns about nerves or nervios or headaches, which, as you can imagine, could lead a physician down a very different pathway than depression. If they take that literally, they might think of an anxiety disorder, for instance, or some sort of problem, some sort of headache problem. Among Asians, weakness, tiredness, or imbalance might be the presenting complaint, which you might not necessarily think of depression with those kinds of symptoms. And in general, somatic or bodily complaints are very common among all of these groups. Among African Americans, concerns of being very irritable or evil, which is a cultural idiom that describes someone who is sort of crabby, difficult to get along with, and can easily be misunderstood as a person who's just a pain as opposed to someone who has a mental health need and depression. This is particular concern with men, African American men, who are often misunderstood, and when they experience anger, people are afraid, and then they start thinking of them as a bad person instead of someone who needs our help and attention.
Well, one of the things that I've known to occur often is that men, African American, but other men, often their depression is communicated by irritability. And so often people completely miss the boat. And I remember a specific case where an individual was described as this kind of hard-working but very irritable individual who was hard to get along with. So people were in fact surprised when he killed himself. So in this case, as far as we can tell, the depression was really being communicated by his kind of irritability. And that's, I think, a concern especially for men. I guess one of the other questions, though, is how do we begin to decipher these complaints that are somatic complaints or complaints about things other than depression? How do we decipher them so that we understand that perhaps what we're really dealing with is a depressive illness?
Well, I think we need to be prepared to probe, to ask a number of questions. Don't just stop when the person says that they're angry. And in making a diagnosis of depression, it doesn't hinge on one symptom anyway. It's usually a number or a cluster of symptoms. Really, any disease is composed of a group of symptoms, not just one alone. So we would want to look at what company does the anger keep, if you will. Okay. If the person is also having difficulty sleeping or low energy, difficulty concentrating, low self-esteem, those might be clues that something else is going on, like depression. So we should never stop with just anger or any single symptom to hang our hat on a given diagnosis. We need to be thinking about, well, what else is going on? And of course, asking family and others to maybe get some more clues if the person themselves is not forthcoming.
Okay, so let's assume that we know that we have an individual that is experiencing clinical depression. What are the treatments? What can be done?
There are a number of treatments. Certainly medication is one type of treatment, and over the last 10, 15 years, there have been a number of developments making antidepressants much more available. There are several out there, so that if one doesn't work, perhaps another one will, and they're in different classes and categories, so you can go from one class to another if the first one doesn't work, and they have different side effect profiles. So that's really a blessing that we have so many choices now. In addition, psychotherapy or counseling is a very important part of treatment, and ideally should be combined with antidepressant treatment. But people can get better by having psychotherapy alone, which is really fascinating, that just in speaking with someone in a confidential fashion, where they sort of help you understand the illness, perhaps help you see things in a much more positive light, can actually have an effect on the brain chemistry and structure, and it really does work. There are other treatments, electroconvulsive therapy or shock treatment, which, although people are sort of uncomfortable about it, generally it is very effective, especially for individuals who have severe depression and perhaps can't take medication, or perhaps the treating person does not want to wait for the medication to kick in, which usually takes 2 to 3 weeks to really start working.
But generally what I hear you saying is that if you were to put together an ideal treatment, it would probably be medication along with psychotherapy or talk therapy.
Yes.
Now, big issue, especially in minority populations. Folks don't want to take the medication. The things that I continue to hear are concerns that it's going to be habit-forming, addictive. Is that a real concern?
These medications are not addictive, but they should be supervised by a physician, and if a person decides that they don't want to take them anymore, they really should consult with a physician and not just stop them abruptly. But these medications are safe and effective. And of course, if somebody does not want medication, it's good to know that there is another treatment available that is also effective, and that is psychotherapy. And for those people who have what we call seasonal affective disorder or seasonal depression that tends to come with the fall and leave with the spring, there's certain types of light that are very effective in treating that. And so there are different things that we can do if people are adamant about not taking medication.
However, if you have diabetes, if you have hypertension, if you have some of the other illnesses that are very common in the minority population, you take medication, it helps control them. There doesn't seem to be the stigma that's associated with that. When we talk about antidepressant medication, then we have this concern. And one of my concerns is that individuals, in fact, are prolonging needless suffering because of what I believe are misconceptions about the medication.
That's true, and that's of great concern, because with most illnesses, the sooner that we intervene and deal with them, the better. The longer that we wait and let a lot of time elapse, the greater the risk is that the outcome is not going to be, the best. And we do know that among African Americans and other people of color, that depression tends to be more chronic and disabling. and some of that is attributed to the delays in seeking treatment.
But there also is the issue, is there not, of the relationship, let's say, between depression and diabetes, depression and hypertension,
Yes.
depression and, individuals that have had heart attacks, and there's some
Absolutely.
issues there in terms of recovery. So these are really important things, I think, for people to hear and understand. The other thing that I have to address, notice I have my own agenda, I'm not being shy about it, is the issue between the faith community, prayer, and mental illnesses. And can you just say a little bit about whether or not, I believe that prayer can be very, very helpful, but people that are depressed can continue to pray and take medication, can they not?
They can, and we really advocate for the two to go hand in hand. For people to keep their faith, to be prayerful. That is very helpful, and it's really an affirmation of their seeking of mental health. And so people should continue to engage in treatment for their mental health need, whether that be medication or psychotherapy, and continue to pray. And these are some of the things that we've been sharing with the religious community, because we in the mental health community see them as important partners and really as gatekeepers for individuals in their congregations who may need more help than they can provide.
That's very important. And what kind of work have you been doing with the faith community in terms of trying to get the message out?
Well, I've been working with Dr. Michael Torres in the Center for the Integration of Spirituality and Mental Health to educate people in the faith community, religious leaders, about what illnesses like depression are, what are some of the signs and symptoms, even how to screen for it, so that they are knowledgeable and equipped with tools for how to identify when someone that they're working with in their congregations may need help. And then, of course, making sure they know about resources for crisis services or counseling, psychiatrists and others who can provide additional care. And that's been a very successful endeavor.
Well, as always, seems like we're running out of time for this show, but I want to thank you for coming in to be with us today. I know you have a very busy schedule, you travel a lot, your time is sought after, and I just can't tell you how much I appreciate the work that you're doing across the country. Thank you for coming in.
Thank you.
And thank you, viewing audience, and remember, if you or someone you know needs help with a mental health problem or crisis, you can call Baltimore Crisis Response Incorporated 24 hours a day at 410-752-2272. And remember, your mental health matters to us.